Hi, everyone. Welcome to GBMC's Facebook Live. My name is Reagan from Mix 1065. Thanks for spending part of your Monday here with us. We're going to answer some of your questions. We've got Dr. Allison Jensen with us. She's a board-certified pediatric ophthalmologist, which is fun to say. And also, we need to find out, what is ophthalmology?
Yeah, so ophthalmologists are medical doctors. We go to medical school. We're surgeons, so a lot of what we do is eye surgery. We also treat general refractive problems like needing glasses. So we're different from optometrists who don't go to medical school, and they do more of the healthy eye vision check and some routine stuff. But we're full medical physicians.
You're seeing everything,
exactly.
Especially with the surgeries, and we've got lots of questions coming in. You can type in your questions here. We've got Mindy ready to tell us what your questions are, but we'll just go ahead and get started. First, what are some normal or expected eye concerns for newborns? Tearing eyes drifting, or crossing in the first few months? I know with my Adeline, things would crust up a little bit.
Yes. Newborns have very poor vision, which does cause them to have the ability to not look you right in the eye. Really, for the first 3 months. It's normal for a baby to have some crossing of the eyes, some drifting, and that really has to do with their level of vision at that point. But by about 3 months of age, they really start tracking well and looking you in the eye. So if your child is crossing their eyes or drifting after about 3 months, that's when we are concerned there's something going on causing that.
Is there a distance, like 3 months they can see a couple feet, and then 4 months
That's a great question.
More?
So kids under a year, they really only can see sort of like 4 or 5 feet. So right in front of them is really where their focus is the first few months. And then by about a year of age, then they really start caring about what's happening, across the room or whatnot.
My 10-month Adeline follows me when I go into the kitchen, and she watches me, I swear.
Oh, yes.
So I think she's a genius.
Yeah.
Right?
Absolutely.
I just got that. How early can a child be examined by an ophthalmologist?
Oh, we see babies in the preterm NICU, so there is no too young for a pediatric ophthalmologist. We use prisms and fixation devices and lenses to get really a complete exam. We can determine which eye is fixating, if there's one fixating more or less than it should. We can measure an amount of crossing or drifting. We can get the exact prescription for glasses without any child interaction.
Wow.
So there really is no age that's too young.
So is there anything that should indicate that you should see an ophthalmologist?
Yeah, that's another great question. So when a family has a family history of any pediatric eye condition, and by that I could discuss the term lazy eye, because that's a common term that really means so many different things to different people.
I had no idea.
Some people refer to lazy eye and they mean the eye is drifting out. Some mean the lid is low. Some mean the vision's poor. So if there's a family history of any of those things, early childhood glasses, a droopy eyelid, an eye that's misaligned, that child actually really should be seen by a pediatric ophthalmologist by about a year of age. Because if we find these things early, it's a totally different ballgame in terms of how we treat, how long we have to treat, and really what visual outcome or potential the child's capable of having.
And problems with the eye can cause problems everywhere else, right?
Yeah, I mean, it's, vision, of course, is one of our very important sensory, conditions, and so we know that if there's a problem and it's not treated early, sometimes or many times as a child, then as an adult it's not treatable. So again, if there's an issue going on, we really want to catch it early, and earlier the better, really.
So beyond infants, with children, what should you be looking out for with?
So some of the signs can be just an obvious physical, like you feel like the eye is crossing or it looks like it's drifting off. That's an eye muscle problem, again, often referred to as lazy eye, but specifically like esotropia or exotropia. If they're doing a persistent head turn or tilt, they may be doing that to accommodate for some sort of eye muscle problem, like they always tilt their head one direction or another, or squinting. Another really common sign of an eye muscle problem is they'll close one eye because they subjectively have a second image or double vision, and don't really realize it, so they'll just close the eye. So those are some symptoms that we want to see a child for.
I imagine you tell parents to ask teachers a lot of times too, because the teachers probably notice a lot of those symptoms.
Yeah, many times teachers and daycare providers, in addition to physicians and parents, those are sort of the different people that we get referrals from, because it's not always the parent, because when you're the parent and see the child all the time, sometimes you can miss something. So if somebody says something, oh, I think little Johnny is doing something, it's probably worth checking out.
So Maria asks, how often should children have an eye exam by an ophthalmologist versus a routine check of the eyes by the primary care doctor? And how valuable are the school eye screens that are done? And when should they be done?
Okay, another great question. So the pediatricians actually, and the primary care doctors actually start screening children really from very early on with a light reflex. They do also check, there are some new photo screening devices that the pediatricians are getting in their offices where they screen them even to a higher level by about 18 months, which is wonderful because we're picking up some of these more serious problems way earlier.
So screening the irises and all?
Yeah, they do it's a photo, and then the photo can pick up any muscle deviation or different power between the two eyes, which again are sort of the big ones you want to get early, which is pretty amazing. So we've been seeing a lot of kids in our office for really appropriately failing these screenings, and it makes a difference between, you know, potential lifelong visual deprivation or not. The school screenings are also amazingly helpful because they are sometimes in the pre-primary school or once they enter the official school system, kindergarten, first and second grade. And again, they pick up things that, you know, parents might not have realized was important or significant. Yeah. So it's really, really helpful. And then, of course, the pediatricians as well.
How about a blocked tear duct? What do you do about that?
Yeah, so that's another really common infantile problem. Basically, the drain from the eye to the nose often is really, really narrow or blocked by a little membrane in newborns. And usually, if a child's going to outgrow it, they outgrow it by about 12 months of age. So typically, we don't see patients until about that age because most of the time, the parents are sort of waiting for it to be outgrown. Now, sometimes when it's really bad and it's just they have like constant everything, we see them earlier. But one thing parents can do, I tell my patients, parents to, as frequent as diaper changes, you wash your hands and put your finger right where the skin of the eye in the corner is, and you sort of press, and you really can't press too hard. You just kind of push, and sometimes you get a little tear reflex. Mm-hmm. Do that, you know, 4 or 5 times a day, and that can sometimes help the opening or the membrane get dislodged. But basically, usually, it's just going to be outgrown or not. And if they're outgrown, wonderful, nothing to do. If they don't get outgrown by about 12 months of age, we do a tiny little probe where we sedate the child and just go through the normal anatomy. I literally could do it to you while you're awake. It's not like the most fun thing. Yeah. But it's a minor procedure, but we do have to sedate them because obviously we don't want to harm their eye while we're doing it. So it's easy to do, but we generally wait until they're around 12 months old to do that.
Wow. I found that comes up a lot with talking with our doctor. They generally outgrow it, whether like it's an allergy or something like that. We've heard that phrase.
Very true, very true.
So we've talked a little bit about the common symptoms that you're seeing. Are there any others that you haven't mentioned?
So a lot of the young school-age children might complain of blurry vision with reading. That seems to be a lot of why patients come to see us, and it really is important to make sure there isn't a focus problem, because if there isn't, maybe there's a processing problem with reading, which we're seeing, you know, diagnosed in younger kids, which is great because if there is a processing problem, we want to find out. But there's a condition called convergence insufficiency where when you're looking at something up close, if your eyes can't come together, you can have problems with double vision, blur, and headache with reading. Now, it's fairly uncommon in kids, but we certainly like to identify it. And then it's an easy exercises at home kind of thing if they have that. Generally, kids don't need reading glasses because their focus up here is perfect. If kids need glasses, they need them all the time because they, you know, if you have astigmatism or nearsightedness or high farsightedness, you can't really see without them. Now, you get into my age in your 40s, and then reading glasses are, you know, very, very common. Yeah. So generally, if kids are having a problem with reading, it's really either a muscle problem or, like I said, a processing problem. And it's important to figure that out. And so if they see a pediatric ophthalmologist, that's really easy for us to distinguish.
That's great. This is a question about testing. Is it necessary for children to get their eyes dilated every single time they have an exam? It seems unnecessary. Please shed some light on the issue.
Yes, that's a very easy question. So any child who's in glasses really needs a dilated exam. And the purpose of the dilated exam really isn't the dilation, it's the relaxing of the focusing. Because the way we figure out exactly the power of lens that child needs is by looking at the physics and optics of the eye. And we can't do that without relaxing that focus. If you don't have your child's eyes dilated and you get a pair of glasses, there's a very large chance the glasses are not correct. Because young people, again, getting back to this focus thing I was talking about a minute ago, I could put 20 different lenses in front of a child, and their lenses are so young they can focus through all those. only one of them is the correct one.
Wow.
So it really just has to do with the focus of the eye and having that relaxed with the dilation. Now, if you don't wear glasses, then we absolutely can defer dilation, and we do it all the time. You know, sure, we can't get a great retina exam, but in a healthy child, that's not necessary every year.
Are people concerned about the recovery process? Is that why they don't?
Often they are, and my little thing I say to all my parents and kids is, yes, you can go back to school, your ears still work, and far away is not affected. So really, as with most things, kids bounce right back. They really don't mind. Even the little babies and whatnot, they're resilient. Us adults, we really don't like having our eyes dilated. We're we're kind of miserable after it. But kids are really fine with it.
All right, Olena asks, says, my 7-year-old daughter has a lump in her upper lid probably for the past 2 or 3 weeks now. It doesn't bother her, no discharges, no redness. It looks like chalazion?
Chalazion. Yep.
Is there any other treatment besides warm compresses? I'm not so worried right now, but when should I be worried?
Oh, yeah, great. Thanks. Great question. So, yeah, styes, chalazion, hordeolum, they're all a different name for pretty much the same thing, a plugged up gland of the eyelash. And warm compresses really are the heart of the treatment. But when we say warm compresses, we don't mean like a lukewarm towel once a day. I tell parents, remember the rule of 5. 5 minutes, 5 times a day. No one really does that, but 3 to 4.
Yeah.
For about 5 days. So as soon as you see this little start is when you want to go with the heat. And you really want hot tap water, you know, and you dip the towel in every 30 seconds and really try and get that on the chalazion. But after about a week, we consider that chronic, and then the heat doesn't really make any difference at all. So for this patient, if it's been there more than a week, they really just have to be patient. It will absolutely involute and go away on its own, but actually it can take many months to totally resolve. Now, as adults, you can go to the ophthalmologist, they'll give you some local anesthetic, they'll be able to remove it really quickly in the office. With kids, we really don't have that ability, and we rarely sedate them to do that because it's just too much to do. But the heat, 5 minutes, 5 times a day for 5 days is a really great way to help them not become this large chronic bump.
Okay, so she needs to contact GBMC.
Well, she really, to be honest with you, once it's chronic, then we just have to wait.
Okay.
Yeah, so unless the child's old enough, and sometimes they are, where they're like, I cannot live with this for 3 months, then we'll, depending on the age of the child, I mean, I certainly have been able to do some local around some older kids.
Yeah.
If they're, really stoic. Or sometimes we do take them and do a quick sedation because, again, sometimes for kids it's just too much to wait that long, depending on how big they are.
Okay. Lori says, my son was born with alacrima and hypoplastic lacrimal glands. No surgery, just treatment and monitoring so far. Recently says he is seeing bugs, and I believe he may be referring to floaters. He is due for an appointment. Do you have knowledge and are able to monitor and treat for this condition? Treated by Hopkins, but doc no longer travels to Columbia. Trying to avoid city travel if possible, and GBMC is conveniently located right off the Beltway.
Right.
Allison?
Okay, Lori, well, thanks for the question. So hypoplastic lacrimal glands, interestingly, sometimes lacrimal glands are hypoplastic, but yet there's enough tear film produced. So there really is no need. I have a few patients with that. That's kind of a rare condition. But generally, there's enough lubrication of the baseline lacrimal tissue that there's no dryness. So that really is a condition we generally just observe. The floaters, some very observant children will notice floaters. We all have them. The gel, or the center of the eye, when we're born, it's solid like gelatin, and then over decades it liquefies, so by the time we're adults, especially older adults, it's really almost liquid. And so during that process, you can get this clumping of the gel, and so a floater is really just the shadow that casts on the retina, and you see this little blobby thing. So a little bit of floaters is a really normal thing. Less common in kids, but the ones who are very observant will notice that. As long as it's not a whole bunch of new floaters or they're seeing flashes of light, that's definitely not normal, and they should be seen right away for those symptoms. But an occasional floater for any of us is really a normal thing.
Wow. We're learning all about our own eyes. That's great. Ben asks, can you prevent your child from needing glasses?
Great question. Well, if I had that answer, I'd really I'd have a lot of people happy. Generally speaking, kids who need glasses have parents who wear glasses. So as with so many health conditions, so much of who we are is our genetic profile. We do know that in this my kids' generation, Adeline's generation, there's a lot more of this going on at a very young age. I mean, Adeline probably knows how to use your phone a little bit already.
We haven't let her, but well,
Great,
she does pick it up, and somehow it still swipes in.
Yes, yes. Well, it's our world, and we can't do a whole lot about that. But we do know that there's an association between higher nearsightedness, that's trouble with far away, and this near work that kids are doing. I mean, not only is it in their social lives and whatnot, it's also in the school system. I mean, computers are in most schools, and if they're not now, they're going to be very shortly. But this constant focus here does make them a little more nearsighted. The opposite of that is that there was a great study done in Asia where there's even more nearsightedness, which looked at kids playing basketball 2 hours outside for a couple of years and inside for a couple of years, and the kids that played outside had a slower rate of myopic progression, meaning their nearsightedness got worse slower than kids who played inside. So there's something about being outside which helps protect against that. We don't know whether it's looking at infinity or the sun, but either way, I tell parents one more reason to get the kids outside for a period of time every day, because that makes a difference.
Do you specifically recommend anything about screen time?
I do. In elementary age and younger, really, my rule of thumb from when my kids were young, they're teenagers now, so the rules are kind of out the window, if you will. But when they were young, we really tried to limit screen time to 30 minutes at a time. And on school nights, they just didn't have it. I mean, they're tired. It's just to have them running around outside or do some coloring or whatever it is they wanted to do. But 30 minutes for that young elementary school age, and then they can go do something else.
That's good to know, and I think that's probably harder and harder for parents to keep up with.
It's much harder. I mean, my kids are in their teens, and I think even in their generation, it's really changed.
Yeah.
How we manage this, and it's.
They're looking at younger kids and saying, "I didn't have a cell phone at that age." Right?
Right. And then if you don't get those gadgets and whatnot, you feel almost like your child's not going to be in with all of this. Yeah,
I'm scared of all of
that. It's an interesting journey.
Diane says, my 5-year-old grandson was diagnosed again with lazy eye, and we talked about how that can mean a lot of things. He had an operation for this at 6 months in Knoxville, Tennessee.
Okay.
I need a pediatric ophthalmologist. And do you have any recommendations? Obviously, GBMC.
Yeah, I mean, when you have a child who has a kind of eye muscle problem, they definitely need to see a pediatric trained ophthalmologist, because we, even among ophthalmologists, have an additional need of training with the young children, knowing how to measure the muscle problem, knowing how to treat the vision and whatnot. So again, we'd be happy to see them here, and really most of the academic centers have pediatric ophthalmologists in the region.
Great. Jen asks, can childhood eyesight problems be due to a neurological problem?
Yes, definitely. I mean, part of ophthalmologists are, as I talked about in the beginning, we're medical doctors. So we do diagnose a lot of medical conditions with an eye symptom or sign. So anything sudden, new, changed, any child with double vision, that's a right away come to the ophthalmologist, because children who have an eye muscle problem from early on, they do this thing called suppression where they don't realize the image is double, and so they don't have double vision. But if you have a double vision complaint, that's a concern of a definite neurologic problem. Wow. So they need to be seen right away. And there are many other conditions, systemic conditions, that we see eye conditions with. So if your child does have well, that's actually a great thing I wanted to just mention. Any children with special needs or developmental issues, it's really a good idea to have them seen by an ophthalmologist, a pediatric ophthalmologist, because they might not be able to communicate to you that they're having trouble seeing, as well as a child who doesn't have those things. So that's just something to think about for those kids.
Sure. What are the most common treatments that you see? What are the most common diagnoses and then the treatments? Yeah,
so in our practice, probably amblyopia, which is the medical term for best corrected vision is not 20/20. Okay, and again, some people refer to that as lazy eye, which means the vision is poor. And the cause of the amblyopia is multi-factorial, can be different. One can be an eye that's not straight. So you can imagine if your eye is going in, the brain ignores it, the vision goes down. So we have to treat the crossing by either doing surgery or giving glasses. and then maybe doing patching to improve the vision. Sometimes it's just that one eye is very different in the power of the two eyes, and the eyes focus together symmetrically, equally. So if one eye is really farsighted and the other's not, the brain never gets a focus of that without the glasses. And so that child, again, might not ever develop vision if we don't identify it early. And that's what a lot of those photo screeners are picking up. So amblyopia, which is, again, some refer to lazy eye. Then a lot of the eye muscle problems, crossing in, drifting out, vertical misalignment. And then rarely things like cataracts and glaucoma can occur in young children. Again, rare, And your pediatrician can do a look with a light reflex to check for cataracts. But again, babies are screened by their pediatricians from the very beginning for all this. But my recommendation is if a parent has a concern or a grandmother has a concern, or a physician, it's so easy for us to examine these kids at whatever age, and we really want to see them early to really make their clinical course easier.
That's great.
If any of those are noticed.
Well, a lot to think about. Our eyes to our windows to the world. Our eyes. The human body is really intricate.
It's
isn't it?
It really is. And vision's a hugely important part. So it's exciting for me to be able to help kids in vision.
Really fascinating. Thank you, Doctor. Appreciate you spending some time with us. Don't forget, you can still add some comments on the site here, and we'll get back to you and give you a response. We'll also have the feed, the entire stream of today's Facebook Live up for you to refer back if you want to hear what Dr. Bennett said with any of the, or Dr. Jensen, sorry, with any of the questions. You can go back and see what that was said. And our next radio Facebook Live is going to be January 3rd at 11 a.m. as we discuss cleft palates. You can follow GBMC on Facebook right here. Thank you so much for joining. Enjoy the rest of your Monday, and I appreciate it, Doctor.
Thanks for having me.